Thank you for that very generous invitation. As I look around the room here, there's a number of faces I recognise. I am here to help and serve you. Sometimes speakers at meetings can be here sometimes to give their talk. So hopefully I'm going to cover quite a lot of things, and hopefully you will gain knowledge from that. And also there will be opportunity at the end for you to ask questions. As Kathy said, I'm Christopher Brand, consultant at the Royal Hampshire Hospital. I help the Royal College of Ophthalmologists in their guidelines for age-related macular degeneration. I work with a number of the drug companies on research and also do some advisory work with the drug companies. So, age-related macular degeneration is what it says. It is age-related and it is the macula. The macula is the centre part of the back of the eye responsible for our good central vision, and it degenerates with age. And there are two big broad types. There is the dry type. So if you look around the room or you look at people, and I said to you, put people in order of their age, you would look at their hair, their skin and whatever and say, this person is older than that person. And you would probably get that right. Similarly, when I, as an eye doctor, look at the back of the eye, there are changes there that tells me this eye is older than the eye of somebody else. But an eye that has some aging change, which is dry, can function very well. So a number of people with the dry type of age change have very few or no visual symptoms. It's a bit like saying, at what age are you old? There's no exactly defined point. So people that have the dry type of age change, as I say, can have very good vision, or then in some cases it can progress quite dramatically and have a significant impact on their vision. So to say somebody has the dry type of age change doesn't explain exactly what their symptoms are. It's quite a range. Now with the back of your eye you have the film, the retina, that allows us to see. That is like part of the brain that receives the light and tells our brain what we're looking at. And that is a highly sensitive structure. And underneath that has a fantastic blood supply. Because the back of the eye is doing so much activity, it needs to have a fantastic blood supply. So what separates that fantastic blood supply and the film at the back of the eye is a barrier layer. And in age, we get changes in that barrier layer, and that is what we refer to as dry aging change. Now, in some people, they can then develop a leak across that barrier layer. And we then call that the wet type of age-related macular degeneration. And that is when we then look to start treating the back of the eye. So if I go back slightly first of all, when we look at aging changes at the back of the eye, it is said that 1 in 4 65-year-olds has dry aging change, 1 in 3 75-year-olds, and 1 in 2 85-year-olds. We heard on the news today, the average age for a man now is 85, and the average age for a lady to live is 87. So as we live in an increasing aging population, we're going to increasingly see aging changes at the back of the eye. Now, although age-related macular degeneration is said to be the leading cause of visual impairment or blindness in the Western world, if you talk to a patient or ever mention the term blind, the patient will have some idea in their mind as to what is meant by that, and we as eye doctors will have another idea. Blindness means different things in different countries. So in this country, if you don't see to a certain level on the vision chart, you are said to be either visually impaired, partially sighted, or blind. Most people would think of blindness as not being able to see absolutely anything. For every 100 people in this country that have registered blind, thankfully only 1 in 100, although 1 in 100 is too many, are truly completely blind. So if people are here and saying, I've got age-related macular degeneration, either the dry sort or the wet sort, and their fear is of losing their vision, although we will try everything to try and stop that from happening, I would say to you that it is not a disease that will normally take all of your vision. it is the central part of the vision that is predominantly affected. But even said that, we want to try and stop as much vision loss as we can. Now, some may say, why does this happen? What is going on at the back of the eye as to why have I or somebody else not got this condition? Now, there have been lots of studies, and we believe there is a genetic link. Now, if you say to somebody, you've got a genetic disease, we sometimes think of, if my parents have got it, have I got it or not got it? There is no single gene link. So it's not like you could say, I've got it, my brother's not got it, my sister's got it, and so on. It's a bit like your personality. You can see mixtures of your uncles and your aunts and your parents in there. It is not clearly defined by one gene, although that would be easy to work with. There's more than one gene involved. The other thing is it's aging. So there's nothing we can do about aging. We're all aging. And then there are some environmental factors that play a part. So if we can do nothing about our genes and we can do nothing about our aging, what other things in our life may we be able to do? And the biggest thing appears to be smoking. There are some other things related, but smoking is the big issue. Because at the back of the eye has a fantastic blood supply, has lots of oxygen because it is having to do lots of work, and there's lots of light there. So the light and the oxygen, and there's lots of chemical reactions at the back of the eye. And as a result of those chemical reactions, there's a lot of waste products. 85% of the brain's input is through the eye. That's why some of you probably, when you were younger, if you'd had a bit too much to drink and lay down and closed your eyes, the room would spin and move on you because you're not using your eyes, whereas your eyes can help you stabilise. That's beyond, I would have thought, most of you now. And so what's happening at the back of the eye, when these chemical reactions are taking place, when you are younger, your body can clear those waste products. However, if you have the wrong genetic makeup, say, those waste products can accumulate. If you're, as you get older, the eye will struggle to clear some of those waste products. And if you smoke, it appears that you can, again, the eye will struggle to clear those waste products. So that can be the beginning of aging changes. Now, a few years ago, there was a trial, and they're still advertised now. What about taking additional supplements? What about things we eat? It is now believed, because we don't exercise and have such a hard-working life, we sometimes, perhaps in our food we eat, miss out on some of the nutrients and things that we would like or should have in our food. So we can take vitamin supplements. And there was a trial a number of years ago of taking these vitamin supplements that showed that there appeared to be a benefit in reducing the progression and in one eye and the onset in the other eye of taking vitamin supplements. And so that's why you may see those advertised in health shops, supermarkets, or even by your optician. They are considered to be a food supplement rather than a medication, and as such, most people can't get them on prescription. More recently, there was an additional study looking at lutein and zeaxanthin. That was, again, these supplements in tablets to try and help the back of the eye. And it was conducted over a number of years, and that study didn't show as effective a result. The thing with these, whenever new evidence is brought out, we adapt the way we live. So when the first trial came out, we perhaps weren't as keen on taking additional supplements in our regards tablets or things added to our foods. When the second trial came out, it showed that if you had a good balanced diet with fresh fruit and vegetables, then the addition of supplements didn't seem to make as big a difference. So the second trial showed that if your underlying diet was poor and lacking in a lot of antioxidants and nutrients, i.e. fresh fruit and fresh vegetables, you may benefit from those supplements. But for a lot of you out there, if you're eating a good diet, the additional benefits of the supplements may not be so obvious. Right. Also, those supplements do not improve the vision. They're there to try and stop progression of your vision. Now, if we look at the dry age-related macular degeneration, and we look at people who have perhaps got advanced dry changes and it's having a significant impact on their vision, there are drug companies now looking at trials into treating this type of change. And these trials are about to start, and they will be looking for the right sort of patients. Now, we have looked through our database in Sheffield, and we will then look for the appropriate sort of patients to go in those trials as and when they come along. And that will involve injections into the eye to try and stop the progression of the dry type of change. At the moment, some of you may read in the Daily Mail or other newspapers about other potential treatments for dry age-related macular degeneration. What some of these additional treatments are involve surgery. They're not available on the NHS, and sometimes people can kind of think, why isn't it available on the NHS? The reason the NHS likes to fund treatments is proven are effective. So if you read in the newspaper about a treatment and it's only available privately, it may be because it's very expensive and the evidence suggests perhaps the results are not as good as they could be. So there are potential procedures if you have the dry sort of aging change, whereby you can have the lens of your eye or the cataract removed and you put a magnifying glass into the eye to give a bigger, obviously a magnifying effect. Or you can put lenses in the eye that shifts the images so that if you've got dry aging change and you notice that if you look to the side of someone you can see them better than if you look straight ahead, it will shift the image for you. My caution with those sorts of approaches is it depends what your vision is in the other eye. If you've got one good eye and one reduced eye, your eyes will not cope with the imbalance. If you've got two poorly seeing eyes, then it may benefit the one eye, but these treatments are often very expensive and they're in the private sector. So we'll come on to the wet sort of aging change. So as I said earlier, that is where there is a leak across the barrier layer at the back of the eye, and at the present time the mainstay of treatment is injections into the eye. Now, if we have a patient who presents with reduction in vision, or there is concern by their optometrist there is leakage at the back of the eye, we do a number of tests, first to confirm that there is leakage, and then we will give injections into the arm of different coloured dyes to see where the leakage is at the back of the eye and what sort of leakage we're dealing with. Because that will help us sometimes to give guidance to the patient as to how serious the change is, how large an area of leakage there is, how that area is best treated, and also if it is another condition which we weren't expecting at that moment in time. Now, there are 3 drugs available to inject into the eye. Now, you may have seen in the press things, there are 2 that come from the drug company, and there is another drug which is cheaper. Now, the issue with things that you read in the newspapers is that there can be an element of truth, and then the truth is kind of polarised, it's pulled apart somewhat, and it leads to some uncertainty for patients, and they can become misled. In Sheffield at the moment, we use all the approved medications as is recommended by the government group NICE, and that have been appropriately gone through all the appropriate trials for use in the eye. The General Medical Council protects doctors like me and patients like you, that says if there is a drug that has been shown through scientific study to be effective, that drug must be used as opposed to a drug that hasn't been through that testing. That, as I say, protects the patients and the doctor. What is happening with this other cheaper drug is some are saying if it was used, it would save the NHS a lot of money. If the powers that be break that rule for this one drug, how many other times would they need to perhaps break the rule? So if it was straightforward, it would have been resolved, and because it's not straightforward, that's why it hasn't been resolved. The other thing that you may have read in the press about the 1 or 2 drugs being more expensive than the other drug is because on the NHS we have a monopoly, if you like. The drug company sells the drugs to us at a cheaper price than is available to the rest of the world. And it has to be done in secret, because otherwise the eye department could sell the drug to the rest of the world and make a profit, be like the middleman in a deal. So we don't. So we get the drug at a cheaper price than is quoted in the paper, and the cheap drug in the newspaper is more expensive than they're saying. If that cheaper drug was to go through all the tests, it would then become a more expensive drug. So I reassure people here that we are using all the government-approved ones and all the proper drugs. Now, the main aim of treatment is to try and improve the vision or stop the vision getting worse, and also to monitor the other eye if it has good vision. And what we know from our own results is the sooner we diagnose and pick up wet age-related macular change, the better results. The sooner we treat, the better the results. And also, if you're a younger patient, your eye has more resilience to what is going on than if you're an older patient. So that's why it's important to have regular eye tests, or if you're in any doubt about your vision, attend your optician, GP, seek referral to us, or you attend Eye Casualty if you think something urgent has happened to your eyes. Okay. Now, one of the pressures that there are, because we've got an ageing population with increase in demands, is the pressures on the eye department. And I've been asked to cover that because around the country, the level of care can vary enormously. In any service, there are 4 aspects to the service. You've got the staffing, the space, the equipment, and then the information technology, your computers. So in Sheffield, like lots of other centres, we're using consultant staff, other staff within the department where we're extending their role, some of our nurses, opticians, orthoptists, and we are using staff to do things that they perhaps didn't do in the past, but we're training them up, as well as trying to make everyone work more efficiently by our own practices. So this is happening everywhere. Because of the expansion that is required, there isn't sometimes the doctors around to do all the jobs that may have historically been done by the doctors. There's then the issue of space. If we go to the powers that be in our hospitals and say, we would actually like more space, the first thing they say to us now is, are you using these facilities in the evening and at the weekends? And you may have seen that in the press. So there will be more pressure on, or a greater need to work at weekends and in the evenings in the coming years. So you may say, oh, I've got a clinic appointment on a Saturday, or it's now in the evening. And again, those will come, because that will help some patients. You won't have some, the travel may be easier, and your family members may be able to help you. And then the other aspects, this is the equipment. If you buy expensive pieces of equipment, the hospitals won't want you to not use them, to sit there idle. So it's important that as you build this business model or try to meet all the needs of the service, that it's all used efficiently, because it's our money, it's the taxpayers' money. And those of you that are treated in Sheffield will know we are using electronic records now for the notes, and we have the images are sent electronically, so that if we do things in different hospitals in the future, we don't have to ferry them around, because we can just go on the, your computer system, it's all there. So, I've been asked also so we're giving injections for the wet sort of macular degeneration, spoken a bit about the capacity, and then the array therapy, this X-ray treatment at the back of the eye, or low-dose radiation for the wet sort of age-related macular degeneration. A few years ago, there was a trial, and all the patients in the trial had the wet sort of age-related macular degeneration. Half the patients were given the X-ray treatment, and half were not. Those receiving the X-ray treatment didn't know they were getting it, and those that didn't know they weren't. It would be a bit like me sending all of you to the X-ray department, and some of you having the X-ray and some not. You wouldn't really know whether you got the treatment or not. When the results were looked at the end of 1 year and 2 years, it showed that those that had had the X-ray treatment seemed to need fewer injections than those that didn't. But it didn't work in everybody. It's like every sort of treatment. It doesn't work in everyone. So what we then did was we looked at the results to try and choose which patient the results seemed to work better in. And those are the patients that we offer the X-ray treatment to. It's not that we're trying to say, you can and can't have it because we've just decided. We're trying to make the right clinical decision for the patient before us in offering the treatment. And the aim is really to reduce the number of injections. Now, whenever anything new comes along, the or the company involved with the product, in their advertising, want a particularly good example. So if you're going to advertise football boots, you wouldn't get me to do it, you get someone like David Beckham. Similarly, if you're going to advertise or let people know about a new treatment, you get somebody who the treatment worked well in, and then, because obviously it raises a lot of publicity. So in Sheffield and surrounding areas, the AREA or X-ray treatment is available on the NHS if you have the right sort of change. And we're collecting our results on that, and at appropriate meetings we will present that to the scientific community. And there is a trial also going on around the country for because some people living in some areas are unable to get this treatment on the NHS, so they can enter the trial. Now, what does the future hold? Because there is an increasing ageing population and the drug companies can see the profits, a lot of the drug companies are investing in new treatments because they can see the potential gains for themselves. So what is coming, I think what we're looking for is drugs that act in the eye longer. I look here and I can see people that come back every month for an injection. If we got a drug that could last 2 months, that would potentially mean 6 visits a year rather than 12. If we got a drug that could last 3 months, that would be 4 visits rather than 12. And if we got a drug that could last 4 months, that's 3 visits a year. Because you've got better things to do than come up to the hospital to have a treatment if you can have it fewer times. And that is our goal for the drug companies, and that would be our goal for the patients. Now, a thing that often comes around and is spoken about is things like, where are we at with stem cells? Let's say stem cells are the cells in your body that go on to make other cells. And there are 2 broad categories of stem cells. There are donor ones and your own. So for example, if somebody took from my body or somebody else's or a fetus's body, and there are lots of ethical issues here. So if you got the stem cells from this, from a fetus or from somewhere that was not yours, and it had to be given to somebody else or was given to somebody else, there are 2 issues with stem cells from someone else. Is, will your body attack the stem cells? And if your body's going to attack it, we would then need to give you drugs so you don't reject it, a bit like patients that have a kidney transplant or a heart transplant. Or would the cells coming into your body expose your body to a risk that they may attack your body? So there's that aspect of stem cells. And then there's stem cells where they take a cell from your skin, and from your skin the scientists are able to make cells of the eye or the heart. And those secrets of how that is done are kept very secret. Because can they take your cell and make your own eye tissue? Now the research, as far as I'm aware so far in this, is looking at inherited eye disease. So that is disease where patients have inherited a problem at the back of their eye. It affects the back of their eye and their vision. And at the moment the trials are taking place in patients that are severely affected. Because in any treatment, it's to do no harm at first. So if you're not sure if this concept will work, what you want to do is you don't want to do any harm, and you want to see if you can do some good. So those trials are ongoing and trying to collect data. And I'm sure if those results are successful, we will all hear about it. As far as I'm aware at the moment, they're not being used in the age-related macular degeneration group, because in the wet sort, we've got the injections, which is doing very well in a lot of patients. And the dry type, there's such a wide range of outcomes that people would say, didn't that just happen by chance? because it's quite invasive to do this sort of procedure. So, as I say, they are being used in inherited eye disease. I've come to the end of this talk. I don't know how Kathy's going to organise this, but I think that's just short of half an hour, 25 minutes. And now I'll try to answer your questions that you have as best that I can. So thank you very much for listening.